Hi everyone. Just wanted to go over some items from our slides this week or from our text, but then also talk a little bit about our information we're talking about outside of the text. So, first, I want to talk about the text-based information. Our topic this week is policy modification, and I kind of dovetailed the continuing discussion about social determinants in healthcare and health disparities with policy modification, because as you'll see as we talk, the reason that we modify policies is often to deal with the consequences of those policies, and oftentimes those consequences are truly impacting those that are impacted by other aspects of their life, lack of food, lack of access to care, etc. So we'll just talk about a few of those things. I apologize you're not seeing my lovely face this week, but I'm sure it doesn't bother you too much. So, and I'll get to see everyone. I get to see a bunch last night. I'll get to see the rest tonight, hopefully in the live session. So policy modification is just part of the overall legislative process, rulemaking process, and even implementation in organizations. Throughout these activities, and we'll talk a little bit more about each area, you'll see how policies end up, we end up seeking modification of policies because of political pressure, because of inability to work with the policy as it stands, etc. So one example here mentions, and this is outdated. I'm sure it's probably double that many now. How many attempts have been made to repeal or modify the Affordable Care Act? During the time of Obama's administration, even though they put it forward and passed it, there were still many times that they were trying to revise it, repeal it, modify it, and then once Trump came into administration, obviously they wanted to just repeal the entire thing. Obviously that didn't work. We're going to talk about incrementalism here in a little bit, and that's a key part of policy modification. You can't just you don't throw the baby out with the bathwater, I guess is the term. You need to make small steps to improve policy, especially when we're talking about healthcare. So if we go back to this handy dandy little exhibit that we've been looking at throughout all of our discussion, we're down here now in this modification phase. So, how do we move forward to revisit, modify, make changes, etc., that entire process? So, we go through implementation, and then by doing this evaluation phase, this feedback loop here, it may lead us to modification. But then we also do modification through the formulation phase, and you see that, especially with formal statutory law, you see that in committees, in the Senate and the House, et cetera, at the federal level. So both pieces kind of feed down into this modification process. Think about the difference between initiation of policy and modification of policy. Policy initiation is fairly rare because what we see most often is a modification of a current policy. And we'll talk about this a little bit further as well, but it may be a change to a current law, like the ACA, just making modifications to it. It may be rulemaking on behalf of a law. For example, every year we receive new rules, and rulemaking is administrative law, remember, as we talked about last week. So every year we see new rules, that govern, which are laws ultimately, but that govern how Medicare pays for things. So actually, I'm pretty sure just yesterday, the inpatient prospective payment system proposed rule came out for us to all look at and determine how Medicare will be paying for hospital stays next year. They submit that rule to the public. We all have the chance to comment like you had in your activity, and then you'll come September timeframe, we'll see that final rule come out, so that we can adapt to it. We do the same thing with the physician fee schedule every year. They submit a new rule. Same thing with the outpatient prospective payment system. So Medicare modifies their policies every single year. And you see policy modification going on constantly throughout the healthcare industry. As the slide here says, most health policies are just a modification of a prior policy as opposed to a brand new policy, brand new law that's taking over. So as I talked about, Medicare is kind of the biggest culprit of this that we deal with on a regular basis. It started way back in 35. The initial policy was the Social Security Act, and at that time, there were many people that were very much for the Medicare program moving forward with a program that would provide health coverage to do folks in their senior years as well as health coverage to disabled folks. But at that time, they chose not to include it in 35. And then as we see, amendments came until 1965 when they actually did amend the Social Security Act so that the Medicare program was created. But so Medicare itself was just a policy modification. It was not an initial policy, and that's how you'll see, and especially if you find all of this stuff kind of interesting and dig into compliance work or regulatory work in some way. When you review those proposed rules in the Federal Register, they're always just a modification of a statutory law. And the same thing with new, there are obviously new laws that are passed, but oftentimes they are just, that new law is just overriding or modifying a previous law in some way. So we've already talked a little bit about that with Medicare. Incrementalism was one point that I wanted to bring up. What we tend to see are just very small incremental steps in changing policy over time. And it's based on feedback. So it is a feedback loop, either at the formulation process or during that operational phase. But as we see how things are working, or as we talk through how things may not work or need to change, small incremental steps are taken. This refers to ACA as being a large modification. I guess the initial policy itself was, but as we see changes to that, as we know, the Trump administration did want to do a wholesale repeal on that and realized that type of a change was not appropriate. So they did actually go with a more incremental approach, removing things like the individual mandate, things that they felt were problematic to the American people, and by just making these small changes, it can be frustrating to those lobbying for the larger change, but it also creates stability. So if we had gone, just think about the ACA. For those of you that are kind of out there and working in the field right now, think about the Affordable Care Act. If you were working in a healthcare setting when this was passed and implemented, it was a massive wholesale change for the way we did things in a lot of cases. So that itself was difficult. But then, as we started to hear Trump administration wanted to just pull the plug on it, that in itself was frightening because we had now just adapted to doing things the way the ACA put forward. So many more people insured, so many more providers needed. We hired providers, we changed our processes, became more efficient so that we could treat more patients in a shorter period of time. And then, they're going to pull back and dump this law. Wasn't the best option for either the people, the American people, or for providers, for healthcare providers, because that would have made yet another massive change in our the way we do things. So incrementalism, little baby steps, is really the way to make change to policy, and it also allows for for a compromise. So by making these little baby steps, you are obviously able to compromise in a way that, okay, well, we'll give you that little bit, but then we'll push for our thing that we want over here. For example, they did away with the individual mandate, but let's work with states to get more to come on to Medicaid expansion, et cetera. So compromise is key in modification. So some of the different roles, I'm not going to go over these in detail, but it's certainly in your textbook. Legislators, obviously, during formulation, implementation, operational phases, they are stimulating modification by moving forward with changes to laws based on feedback, either feedback through committee if it's something that's still in formulation, feedback from constituents. That's what we can provide for them. And then also during the implementation phase, if they see that something's not working, they can act to put new law in place that would override that previous policy or make modifications to the previous policy. Executives obviously monitor implementation phases and make modifications to their to their rules. So when we think about Medicare and the Center for Medicare and Medicaid Services, that is where, okay, we're implementing this law. What does Medicare have to change in their rules? That because Medicare falls within the executive branch. What do they have to do to meet these new needs in these laws that have been passed, or what can they do to modify rules, operations to make sure that they can meet the needs of policy as it stands or of modifying certain policies. Example is how every year we have these new payment rules that come out from Medicare. Just like most of us work in a job, we get reviewed every year and then we might get a raise, hopefully, if we're doing a good job. Same type of thing with the changes in payment rules. You'll usually see some increase or maybe just a flat standard rate across different payment programs because obviously cost of living is going up, so they're looking to increase rates. But then you'll see them cutting in other areas to try and make it budget neutral each year. So those types of changes modify policy over time. And then the courts obviously get involved from that common law aspect to make modifications when needed, when there's problematic policy. And just a brief example of that, it didn't result in a modification, but it kind of standardized when the Supreme Court took a look at the ACA and said, yes, it actually was constitutional. So, but there was a question prior to that. So it can occur anytime in the policymaking process, this modification element, but it is more likely to take part either in the legislative development piece where they have a piece of legislation and they're molding it and changing it, or at that rulemaking phase, so that administrative law phase when the executive branch is making rules based on policy created by legislators. So just to kind of take the different steps that we've looked at, we've kind of talked briefly about already. So when you're making modification to policy at the agenda setting stage, this is where modification can begin. So we're setting an agenda, and we may already have a rule in place on this, but we're setting a new agenda to make modifications to it. Or even if they're in the development of a new statutory law, getting everyone involved in that agenda setting stage, making sure that everyone is on the same page, and perhaps we would need to modify policy moving forward. The legislative development stage, so obviously this is kind of one step behind or beyond that legislative or agenda setting stage. But again, modification is very routine at many stages, so it's kind of a silly statement there. But these are the kinds of things that we'll see at the legislative stage. So new technology may, for example, the electronic health record, a new technology in healthcare many years ago really pushed forward changes in the way our current law is read, which only dealt with health information on paper or being shared orally. So new technologies really push things forward. We're seeing a lot of discussion now of blockchain. So blockchain is it's a kind of a communication standard, I guess. I'm far from a tech expert, but blockchain seems to have there seems to be some worthwhile usages of blockchain. It's currently used a lot with cryptocurrency and trying to keep that safe and private. But there's some healthcare applications to it, perhaps exchange of information between providers electronically, perhaps exchange of funds between payers and providers. So there are some new uses there of blockchain, but how do we keep them safe? and all of that. We would need to modify legislation, modify policy. Budgetary concerns. Sometimes there's a law that is created, new statutory law, or that's in development. Okay, let's provide different types of insights to new laws, new or not new laws, new technologies, etc. And we'll provide funding for that. So, good example is the HITECH Act, which provided funding for new technology, specifically the electronic health record. So you, as a provider, you got access to funds from the government, and then in return, you had to use that technology meaningfully, also known as the meaningful use laws, which have changed as well. They've modified since that time. But originally, the original thought was that they would give providers enough money to purchase an electronic health record. And obviously, from a budgetary standpoint, they realized that was not going to happen. They're very, very expensive. There are different levels of technology available at different costs. So for your effort implementing and using meaningfully an electronic health record, you were able to get a stipend back from the government to pay for part of that. Interest groups, organizations, beneficiary demands. We've talked a lot about that, about lobbying or working with your lawmakers just as a citizen in the U.S. And those types of things can help to pressure legislative development during that initial conference and discussion phase of legislation. And then if another law changes, sometimes that impacts legislative development in other areas. It is that feedback loop. We've talked about that a bunch of times, so I'm not going to beat that to death. So when we have situations where we're modifying through design of new policy, so such as when an organization is given new responsibilities, like CMS, who started out as just managing the Medicare program way back when they were known as the Healthcare Financing Administration, and now over time they've taken on greater roles with Medicaid. Obviously, they're responsible for the Medicare program, which is massive, but then there are many other aspects to CMS. So through the design of these rules or of the statutory law, either of which, organizations can get new responsibilities and then be responsible for creating new rules. So it is an element to be to observe and to understand and to know that although our government in this country has been around for a long time, it is really still constantly changing and shifting as to who has responsibility for what and what types of responsibilities are there. When there is a change in a law or how it is to be implemented, that is also, a design, modification through design. So, the insurance mandate for companies with a certain number of employees, originally there, was to be implemented at this point, and then they pushed that off to help accommodate go back a couple, all of these folks down here, beneficiaries, the organizations themselves that are tasked with implementing this mandate. So they make changes to these things through that design process. Modification through rulemaking is where we really see modification on a regular basis. And so rulemaking, again, is that administrative law phase. It's when organizations within the executive branch, such as CMS, because they're the ones we see most often, Department of Health and Human Services, CMS, are making new policies or making modifications to policies through their rulemaking phase. So we've already talked about rules on Medicare payments frequently changing. They change every year. So those types of things, and they can change throughout the year as well. We always need to be aware of what CMS is doing. And that is through that administrative law process, rulemaking, where you're really constantly making modifications, oftentimes just either for budgetary purposes or because they're seeing issues. Like, for example, if A perfect example of this is many, many years ago, physicians under the Medicare program used to get paid for a consultation. Consultation is kind of like, for those of you that maybe aren't so familiar with it, it's like a second opinion. In order to have a consultation, you have to meet all these different requirements. It means you have to be referred to somebody for that opinion. They need to make a written they need to see you, obviously. They need to write a note back to the person that referred them. There's a lot of elements. Physician, and you get paid a lot more to do a consultation than you do to just do a regular office visit. Unfortunately, physicians were very abusive of that and were billing for consults when there weren't doing consults, when there was no referral, there was no written note back, etc. And so Medicare finally just said, okay, we're just not going to pay for consults anymore. Every visit is an office visit or a hospital visit. So sometimes when the Medicare program observes fraud and abuse in the system, they'll usually try and work with providers. If they finally get to a point where they're like, we can't do this anymore, then they'll make a change. Very similar to evaluation and management service changes upcoming to, within the next couple of years, those types of changes. We're seeing a wholesale change on how they make payments for office visits. So again, based on fraud and abuse issues. Operations can also provide us with opportunities to modify. It's less, this may be policy implementation modification. Obviously, a manager in a hospital not going to have a lot of firsthand say in how to make a change to an administrative law or a statutory law, but they will see how these policies implement and then be able to provide insight back to either the agency, such as CMS, that is implementing the policy, created the new regulations, or feedback back to their lawmakers to get that information and make changes to policy. So managers have a tough road to hoe, because especially if we're talking about the federal government, it's a very large bureaucracy and very difficult to make individual change. But we do have the opportunity to do that. We can reach out to our lawmakers. We can reach out to our executive branch organizations like CMS, NIH, FDA, etc., and provide some insight, which is helpful. Kind of plays into this aspect as well, evaluation. Oftentimes, we in the healthcare setting are in the perfect spot to be able to make these types of comparisons. Oftentimes, folks in the administrative branch, in that executive branch, have moved on to the next policy. So we can often provide this comparison. However, there are research arms of the Department of Health and Human Services that do policy analysis and see how things, we planned on it to have this impact, but in fact it actually had this impact. Probably the individual mandate was a good example, where they really planned on that individual mandate under the ACA to force everyone to get health insurance, and in fact it did not. It pushed a lot of people toward getting insurance that didn't, but most of those folks went to the Medicaid program, not necessarily to the health exchanges, and many people actually lost their really good private insurance when they developed the health exchanges. So what they had planned on and what actually happened, two different things, hence the reason they made some modifications. So that's it about modification. The other things that we're talking about this week, though, are looking at disparities in health outcomes, because oftentimes that will help to drive us to having a more impactful policy. When we're creating policy items, legislative items, at this point, we are probably looking more often to impact those that don't have care, don't have access, don't have insurance, don't have food and housing and those types of things. So from a health policy standpoint, we're really looking more at addressing these social determinants of healthcare. So I've provided a few articles on that topic. And our writing assignment this week is about health disparities. However, I did want to, and this is not required. It would have been required. Unfortunately I was unable to get access to it just until last week for this movie. I would have had this be your project for the week, but the library was unable to get me access in time. But it is available to you now. It's a film called In Sickness and in Wealth. I don't think it's too long. It certainly helps to inform this aspect of our learning for this week, but also some of you for your policy projects that you're working on for next week. It can be helpful for that as well. So if you have time, oh, I found a typo there. Sorry about that. If you have time to watch it, I would encourage you to take a look at it. Or if you have an interest in health disparities, please feel free to take a look at it. Even if you don't have time to do it now, maybe you'll have a little bit of time in the break between the terms. Not that there's much of a break, but in that time period before your new class really ramps up, it might be a good watch for you. There's another film as well that we do that I'm still trying to get access to that we watch in the population health class, and it's also part of this series. So really interesting. Can kind of talks about how your zip code is what generates your your level of health, because oftentimes where we live generates that ability to have access, those types of things. So interesting watch there. Obviously, we last night we did have our one synchronous session. It went well. We didn't have a lot of folks though. People signed up and weren't there. So we'll see how things go tonight. I had chosen those because it kind of was a good split. This is a required element of the class, so if you cannot make it to the synchronous session, please make sure that you get in touch with me. There will be an alternate assignment for that. So, make sure that you get in touch with me if you're not able to make it to either of them. And I think that's about it. We have this written assignment you're going to turn in the Dropbox. We do not have a discussion board this week because we have the synchronous session, so I offset that. And I think that's all. So if you have any questions, please reach out. Otherwise, I'll look forward to seeing the rest of you tonight. And if you, again, feel free to reach out to me with any thoughts you might have or questions. Thanks.